from the public in advance of today's meeting. We receive a number of commercial inquiries. These do not form part of the questions from the public, but they're responded to outside the meeting. We have 2 members of the public signed up to attend today's meeting, and our Mirror Board also receive a standing invitation, and I'm delighted to see some of them with us here today. May I move us to the conflicts of interest register? I've had no conflicts raised in advance of the meeting. Are there any conflicts to register in relation to the meeting or anything new more generally? I'm not seeing any, thank you. And could I ask you to look then to the minutes of our last meeting in public held on the 17th of September 2024 and matters arising. I have confirmation of accuracy. Thank you. And any matters arising that are not otherwise covered in our agenda today? No. Thank you. I'm going to move us then to our first item, which is our Chief Executive's report. Over to you, Fiona.
Thank you. So I thought I'd start with a couple of positives, really, just to reflect on. Firstly, it was really good last week to have our annual Equality, Diversity, Inclusion Conference with really high engagement from all our partners, voluntary sector, NHS, local authority partners, all really thinking together with some fabulous speakers, I have to say, on how we really build a climate that shifts the dial on how we address discrimination, and with a particular focus on building our Anti-Racism Alliance in order to address health inequalities through making our staff feel absolutely valued, supported, and we had some really good top tips from the first speaker about what inclusive leadership looks like, and tested a number of us in where we are in our practice as leaders today. And big thank you to Safina and Shay, our diversity leads, but also our partners who both provided panel members and engaged so well with that. Then I really wanted to reflect. Lilith has updated us, but it's worth really sharing this in public, the huge value of our voluntary sector partners and community engagement in our Slough. We have a One Slough celebration annual awards event, and it was great that the community in Slough, through their voluntary sector leaders and process, awarded the Frimley Academy an award for great contribution to community development through leadership engagement and leadership development programs such as 2020 and Wavelength. So and I think of any award you get, getting an award from your local community is probably the best. Absolutely. It's what makes my heart sing, much more so than any plaudits from hierarchy or nationally would apply. And then the third thing is just to recognise that one programme that we support and host is the Tenpenny Agency Collaborative for the whole of the South East, and which Caroline Corrigan, our Chief People Officer, oversees, and we employ the very small but precious team that do the work in that space, and they've been shortlisted for an award in the Health Service Journal Awards, and the ceremonies this Thursday, isn't it, Caroline, coming up? So it's great to get that recognition, and it's making a huge difference to the operational effectiveness and excellence of providers across the Southeast through managing and improving their staff and workforce management and deployment through much better rostering and planning of care and support to staff. And then two other things from me, Priya, in terms of updates for the board and public. We've obviously had nationally the budget announced since we last met, and we've also had the launch of the national NHS 10-year plan. We in the Integrated Care Board and in the NHS are working through the implications of the budget and the challenge. So whilst it is a very positive settlement compared to other public service departments, and it is set in the context of a very demanding economic environment nationally, and it does have challenges for people who provide services and who are part of the NHS family in terms of voluntary sector and primary care, who are affected by some of the aspects of the budget, like national insurance. So that has to be worked through both nationally and for us locally to help us plan effectively for all and maintain a continuing transformation and improvement for our residents. And part of that journey is going to be supported by our now launch public engagement as part of exploring what we can go further, faster with, what we could radically change for the benefit of our communities in designing the 10-year NHS plan. So we've got events starting. Certainly I've had some lovely invitations already to go and speak to some communities, and board members will be approaching you to help as well in your communities or to support more widely across the system over the next couple of months. And lastly, winter. We're in winter. It's snowing in parts of the country today. I've seen pictures. It's very cold, cold weather warnings. We've got real demands in our services and pressures, and we have our urgent and emergency plan both to internal to each of our services in the NHS and in partnership with social care, but also we need our public to get themselves vaccinated where you've been invited to be vaccinated. It's the most important preventative measure that we can be taking as citizens for our own health. And also we need to be really setting up and running with some of the changes that we're making to our urgent emergency care pathway. So we're right in the midst of implementing some improvements, changes to services, which are going to help us address winter safely for our residents. Thanks.
Thank you very much, Fiona. Are there any immediate comments or questions? We are going to be picking up on all of those issues as we go through. Now, before we go to our next agenda item with the engagement plan, please could I ask that we take our EPRR annual assurance agenda item next, and I'll bring in Sam Burrows. Thank you, Sam.
Thank you very much, Chair. Yes, I'm presenting this item to the board today as the Statutory Accountable Emergency Officer for NHS Frimley ICB. And the paper, I think, gives you a really thorough update on our annual position as a statutory body with EPRR responsibilities. The ICB has its own statutory duties, which I think the paper gives a good explanation of, and an update of where we currently are in terms of our assessment against our ability to meet those duties. But just a reminder as well that the ICB acts as a system convener for other organisations working in this local partnership, and to that extent we have included the assessments of our main NHS provider partners in this paper, which are Berkshire Healthcare Foundation Trust and Frimley Healthcare Foundation Trust. In terms of the and I should also add as well, sorry, HCRG, our community service provider in the south of the patch as well. All four of those organisations are, as a minimum, substantially compliant and therefore green rated against their core statutory duties. You can see a breakdown in the paper of where there is some divergence from that position, but it is minor and non-substantive. I'm also really pleased to report to the board that NHS Frimley ST are fully compliant against the 62 core standards which they are assessed against. Taken together, I think the board should take substantial assurance from the current position across the Frimley ICS. There's very strong compliance against the core standards, and certainly in terms of the ICB, for which this board clearly takes statutory accountability and oversight of, there is a full action plan in place to try and reach full compliance against all 47 core standards by the end of the year. Just finally, I will also signal to the board that the main area of forthcoming focus for EPRR is around cyber security. Board members will be aware of a number of significant and notable cyber incidents which have taken place in the NHS over the course of the past 12 months and more broadly in the public sector. Board members will also be aware that it's a particularly volatile situation currently as well, with a number of national and international actors in this space, which the board needs to take further assurance of. We are planning in the final quarter of the year to do a deep dive exercise with the board to give greater visibility around our cyber compliance, given that it is our area of forthcoming focus. I won't say more, Priya. Hopefully the paper does give a slightly richer picture than that, but those are the headlines from my perspective, which I'd like members of the board to be aware of. Thank you.
Thank you, Sam. Very clear, as is the paper. Ilona.
Thank you. Morning all. Thanks, Sam. A really clear paper. Two quick things. One, I really endorse and welcome the future focus on cybersecurity. That makes good sense from my perspective, and I'm sure others. Secondly, just I'm sure this is the case, but if you could just confirm that for each of the provider organisations who are reporting into this piece, their individual assessments have been through their local governance prior to being kind of reflected in this overarching piece. I'm assuming that's the case, but it'd be great if you could just confirm that. Thank you.
Yeah, very happy to confirm that position, Ilona. And just again, for your awareness and assurance, we have both organisational level internal governance, which all of these organisations are compliant with. We also have system governance as well, where we actually bring all of this together to take sides of it as EPRR professionals collectively in the system. So this has been through both sets of those in parallel.
Lovely, thank you.
Thank you very much. Any other comments or questions? Can I have confirmation then of approval? Thank you. Was that, sorry, Karen, is your... No, okay, thank you. Let's move then to our national 10-year NHS plan and community engagement, Reconnect, Reset and Rebuild. We'll be coming to Sarah Bellas, our Chief Nursing Officer, and delighted to welcome also Mirror Board members Asma Aziz, Kelly Knight and Mansoura Munib. Welcome. Over to you, Sarah.
Thank you, Chair. I'm not sure that we have any members of the public with us, and we did have this at our last board, so I'm just going to do a very brief overview of this and allow our Mirror Board colleagues to contribute, because they received this at their session last week. So if that's okay, if we move to the next slide. As you will recall, when we spoke last time, this piece of work came about following thinking about the Grenfell recommendations, connecting with local populations, the Darcy review, and at the same time, the national opportunity around a conversation for the upcoming 10-year plan came about. We considered all of these things, and we thought that it would be an important opportunity to talk well, listen actually to our population to understand, you know, the way they live their lives and the profound effect on the way they live their life have on their health outcomes, to help us work on building on previous engagement and emphasising the collaboration that we need to have between healthcare, individual professionals and the local community. Do you want to move to the next slide, please, Sam? So the purpose of this work was to provide an opportunity for staff, stakeholders and community in the wider public to have an opportunity for a different conversation about health, thinking about short, medium and long-term goals and their aspiration. It was also an opportunity, it's also an opportunity for us to promote inclusive leadership in action and involve our board members and our senior leadership through across the ICS, not just the ICB, to foster new relationships and understand different perspective. And it was an opportunity to feed into the government plans to inform service change and consider the principles of our transformation plan. Ideally, what we want people to is think they will genuinely have an impact on something tangible, because I think it's really helpful and empowering for our population to that. It makes and to feel empowered, excited, energized and connected, and to get involved, be honest, share challenges, connect and continue to be involved as a lasting legacy. Want to move to the next slide? The approach we're using this triangle approach. We're starting with building on our existing mechanisms with our online feedbacks, and then we're going to build that out with additional things, feedback, survey, quizzes. This area is designed to spread across a wide range of areas. Then we wanted to think about a different way of empowering people within our communities. You will recall that we launched the voluntary care sector in the summer, our VCSE, which is a collective of voluntary organisations, and we have empowered them to have a small community engagement fund for them to be able to go out and talk to groups and support us in this work in a way that they can do that we will probably never be able to manage because of their connections and their integration within the community. We're also having a system set of 12 facilitated 90-minute sessions inspired by the inspiration station that we used back prior to COVID, if you can remember back prior to that time, to design our strategy. That's one of the other things that we're going to do. And then the final part is for an ability for system leaders to identify small groups or communities based on their own interest, experience, and carry out structured guided conversations to be able to do that. And many of our board members and wider system leaders have expressed a genuine interest to do this. So it's really exciting. Do you want to move to the next slide? So I think we've got 6 tests for the success of this programme. Our leadership commitment, I think that is already really evident with many of our leaders coming forward. A lasting impact. So what will be different as a result of this work? Leading differently, that individual commitment to visibly taking something from it and doing something with it, shifting the power. This is the start of a different relationship approach for the system. So empowering our population, empowering our VCSE, listening together, who, how and where, and then connected action. How will this impact the way we make our decisions? The output will have a broad range of insight from a broad range of stakeholders for local and 10-year plan. We're going to evaluate and analyse the reports. We're hoping to make case studies and videos on process and board level input, which I'm personally looking forward to having to make podcasts. Those of you who know me well will realise that that probably isn't an area I'm looking forward to doing, but it's an area that I'm committed to trying to achieve. And then a range of community engagement outcomes and the opportunity for the national sharing. Can we move to the next slide? I'm not going to go through the next 4 slides because they give details on the triangle that people will be able to peruse at their leisure. So if we move to the, I think it's the slide on content. Oh no, time frame, thank you. So we've been doing the design process during September and October, and we launched on the 4th of, no, it was last Friday we launched. My dates are all confused as I'm just back from holiday. And we are now in the activity phase. In December, we will pause for input into the 10-year plan. Then in January, we'll start, and February, we'll begin our analysis. And then in March and April, we'll be starting to put together, we'll be sharing our public feedback and listening together. So if we move on to the next slide. The content, and this isn't exclusive, this is just an idea of some of the content that we'll use, and we'll use different people's skills and expertise to have different conversations with people. And in fact, I think one of the areas that I wanted to highlight is around women's health that isn't captured within here. We are really lucky to have Dr. Aya, our CMO, who is passionate about women's health and has worked in this area of specialism over many years in her career, in addition to being a GP. And she is hosting a fabulous webinar tomorrow night on women's health. There you go, Lalitha, shameless plug publicly for your session. And if someone can put a link into the chat, just in case anybody is watching and wants to be involved, that would be really helpful. Can we move to the next slide? How can you help? We need commitment for everyone to make this a success and to ensure a legacy of future work. As I've said, many of you have already signed up to support sessions. If you haven't yet and you still want to, please do let us know. And then we can give out some more information about the different sessions and things that are available. And you can go to our Frimley ICB.communications@nhs.net if you want any more information or connect with them. Next slide. I think that might be it. Awesome. So I'm going to, Priya, is it okay to hand over to the Mirror Board for their contribution?
Yes, please. Thanks, Sarah. Hello.
It was quite a large discussion from the Mirror Board group, but the key points that we felt were most important here, and Mansoura will also pick up some points, are ensuring the monitoring of communities engaged to mitigate smaller, more bespoke groups being missed from the conversation, especially for communities where there isn't VCSE support to actually engage them. There would be a support group I would engage personally for my lived experience, but actually they're not based within the ICB, so that group of people would be missed. And ensuring that there is support for the smaller VCSEs to be able to engage who would benefit from the Community Engagement Fund, as they might not have dedicated people that are there to support and apply for funding and have their finger on the pulse in that way. So it's about supporting those smaller communities who would benefit the most from it. I'll pass over to Mansoura, who's got good points too.
Yep, thank you. So hello everyone, I'm Mansoura. I'm lived experience senior recovery coach facilitator for SABP Managing Emotion Programme, facilitate there and also now at the Recovery College. So some other angles that came forth with this, it's absolutely kind of, we talked about, it's like looking at a kind of euphoric, amazing project that we can get engagement back with the public and develop that trust. So one angle was that we will be asking questions, providing a safe space to speak and share, and we will listen. That's kind of the key gist. But adding to that, we then need to kind of act and deliver on some things that we're asking, and also to let people know what contribution that they've made, what has made a difference. So not kind of promising things, but just to keep in touch and keep that open channel of engagement, which is going to enable us to build that trust back again in NHS, or more stronger, develop more confidence in being listened and valued to, and also then provide an ongoing opportunity. We've got that open channel to go back and forth with different themes, so we're definitely not just reconnecting once, but we're reconnecting, resetting, rebuilding, and providing that circle of change. So some other aspects were that we need to be very mindful on how we ask those questions. So I know things have rolled ahead and we did get these papers fairly recently, but it could have been a greater opportunity to put in some more insight from various lived experience and diversity from the Mirror Board on how to ask those questions. Are we culturally aware enough to be able to go into those communities and engage? And then what communities provide those ongoing channel communication to keep those things open. So we need to be mindful of language, terminology, how we're going to be presenting that feedback so it actually is beneficial and it's actually coming not from a personal perspective of what I've listened, but something that can come together that can then be brought together and be of value, to the trust to take forward. And one other thing, just from another aspect, is that when we ask questions, sometimes they're going to be coming from traumatic experiences. So we need to be able to ask the questions, listen, and provide validation, and in some cases closure to some emotive conversations that are going to be happening. So maybe that also led on to a thought of maybe having in-house engagement officers somewhere down the line who have this ability to kind of provide opportunity for in-house collaboration roles as well. So it's a two-way process. Some services would like to know things, they can go back into the community, but it's building that trust within the NHS once again with consistent people, consistent links, and a consistent kind of department. And that also kind of reduces over asking, because there may be different projects going on which require to go back into the community to enable this engagement. But if we keep going back and keep asking questions, sometimes that can be tiring. So can you imagine if someone comes along with one initiative and then another person comes along with another initiative? We're not going to have that much time to give fruitful replies. That there's so many times, so it'd be good to have kind of central people doing that. And I'm really passionate about having these things within the NHS as well, not just to always kind of give them out. So I hope that was helpful. There are many other points if sure we could bring to the table, but for now those are the ones we thought we'd share.
Thank you very much, Mansour, and thank you to Kelly. That's been really helpful. Sarah, shall I come back to you?
Yes, I mean, they're really helpful comments, Kelly, Mansour, and I'd had the feedback from the team that came to present to you last week, who thought it was a great opportunity. We had engaged with some of the Mirror Board prior to the Mirror Board session at the development, but recognised that we could have done more. Happy to have done that. I think the monitoring of communities is absolutely vital on making sure that we just don't get the same groups that we think we're going to get, and we get the coverage that we want to. So agree with you completely on that. With regards to the small groups, Kelly, absolutely would welcome the leadership across the organisation. When we talk about leaders being involved and going, we are considering you very much as part of our leadership community, so would welcome you going to talk to that group and identify what support that you need to have for that. Agree around the listening, feedback and ongoing opportunity, and making it something that it's lasting and meaningful. And then I think, and I've termed it layering of engagement, Mansour, because I agree with you that people can get engagement fatigue otherwise, can't they? So we have been trying to work really hard with our partners and local authorities to make sure that we try not to do that layering fatigue that you describe, because I think it's really challenging for the population. And I agree with you in terms of the dropping off the edge of a cliff. It's really important that we don't just do this once and then drop off the edge of a cliff. So thank you for all of those constructive comments. I know that, and I'm sorry I wasn't able to come to the Mirror Board, I was on holiday, but I know that I had it reported about how how engaged you all were within the session. So thank you.
Thank you.
Thank you very much, Sarah. Let's open it up to colleagues' questions and comments. Alex and then Paul.
Yeah, firstly, thanks to Mirror Board colleagues. That was really, really helpful. I think when I look at the pyramid that we're looking at in terms of our engagement approach, those two bottom parts, the large-scale listening and outreach and co-produced community involvement, are really fundamental to a change in our success as a health and care system in terms of firstly really listening and understanding. We're going to hear some difficult things from our communities and population, understandably, and then building on what Mansour and Kelly have said, that response and maintaining a connection that co-produces change in the service, so these communities and the population see a difference and see a difference that is related to their feedback. I think is a massive opportunity, but also a massive challenge in terms of delivering this, so that it isn't just an engagement approach, and that our population and communities see a real change that has been directly as a result from the feedback they've given to us, and a continued relationship with our population and communities about this long-term impact that we want to have as a system partnership. Thank you.
Thank you, Alex. And Paul.
Yeah, thanks very much for this work. It's really great to see. It's very high quality in terms of bringing together, quite ambitious in terms of bringing together a very local response to what we're trying to do to support the community here, but also how we dock that response into the national 10-year plan. So it's really good to see that working together. And really just to build a little bit on what Alex has just said, that the kind of key to this is how we complete that feedback cycle. So we know from all experiences of consultation and engagement that the confidence and the trust, you build confidence and trust by being transparent about what you are and indeed in some cases aren't able to do, and so that kind of part of the narrative is going to be really important in terms of how we continue to build a really effective engagement relationship. And I completely agree with Mirror Board colleagues that this is an ongoing relationship process. It's not just for one 10-year plan, as it were. It has to have granularity over a longer period of time. So it's really great to see this, and I think it'll be good to see the kind of the qualitative responses as well as the quantitative responses to this, to really understand what are the issues that are important to people locally, and then where we can play a role as an ICB, but also how we can influence the wider national debate, which is a really big shift for all of us. So yeah, really good to see that. And so just a little bit more clarity about how we're going to do that, I think, would be helpful.
Thank you, Paul. And Ilona.
Thanks, Priya. Thanks, Sarah. It's really good to see this moving forward. And I would echo Alex's comments about the input from Kelly and Mansoura representing the Mirror Board. Great to get your feedback. I'm really excited about this, Sarah, and I guess my question is really just one about how we support the pace and ambition you've got here. So practically speaking, I think the timetable is great, but there's a lot to do in the next few weeks, and I'm really keen to support you, possibly with Kelly, who's my Mirror Board buddy. It would be great to do this in pairs if we can at all. And I just wanted to check, is there a process behind the scenes that's going to support us to understand when things are happening where, so we can practically get things in diaries, etc.? I was just struck that this is now beginning to happen, and I'm really keen that we support you as much as we can. Thank you.
Thank you, Ilona. Let's come back to you, Sarah. Thank you.
Yeah, so thank you, Ilona. And I did see that you had emailed yesterday, and I know that I couldn't get back to you yesterday. It was a exceptionally busy day, and I know that I spoke to Ellie, and I think the team have got back to you to try and talk to you, or they will be today, to try and arrange and support that. So I think it does involve people coming forwards and saying they want to be involved, and then we will match you up with opportunities. Or if, for example, like Kelly, you have an opportunity that you can that you're already engaged in that we're unlikely to cover, then that would be fantastic for you to identify that we can then build that within the schedule. It's not, it'll be iterative as we move through it. There are fixed points, as you've seen that around the sessions that I described, but as people come forward and say the things that they are involved in, that'll be far more helpful, and that will help us to do the piece that Mansoura was talking about, making sure that we try and connect some of those communities. And as we look at what we have done, we'll be able to see where there are areas that we're not covering, and aim to do that as well.
Thank you very much, Sarah, and thank you to all colleagues. That's been very helpful. I have a hand up from Mansoura.
Yes, can I just quickly, just a thought that came in, I think it's a great opportunity as well to connect to other in-house initiatives like the anti-racism, wellbeing and ED&I, just to see if there's any key questions that they would like as well, because we can add those 1 or 2 questions in at the same time and then bring that knowledge back rather than going independently once again to engage back into communities. So it's a great opportunity thinking ahead for those as well. In-house collaboration. Yeah, thank you.
Thank you. And Samina?
Yes, thank you. And just to also say, I'm on the Mirror Board with colleagues, and thank you for reporting back. And I think for me, I think there's also a great opportunity for us as the Mirror Board with our mentors, and I know Lolita's mine, to take on a project here to do some work. Because I think my intersectionality or my passion is around women's health, supporting South Asian women around cancer and other long-term conditions. So I think there is opportunity within our remit of staff, not just the Mirror Board, where people have got these other connections in communities that they can also come forward. So I think, I think this is a great way forward for the Mirror Board to work more closely with our mentors and do something as a duo. And I think Iona gave that example. So I thought that was a great thing just to highlight. Thank you.
Thank you. And thank you, everybody. I think this is such an important opportunity, really, for everybody to be able to shape the future of our health and well-being. So thank you in advance for all of the input that everybody will have. And thank you, Sarah, for your leadership in this. I'm going to move us then to our next agenda item. Again, Sarah, we're going to ask you to lead on this. This is in our Living Well section, and it's our Primary Care Access Recovery Plan. Over to you, Sarah.
Thank you, Priya. Let me get the right notes for what I'm doing. I wasn't going to go through all of these slides because there's lots of slides, but what I wanted to do was to talk to you about the 5-year delivery plan. So you will know that we have been asked to do this. This started in 2021, and we have to give 6 monthly updates on it. Oh, hang on, I just need to move. Oops. So, right, okay, sorry, I'm with you now. So updates, there are 4 key areas within the plan that we are trying to work on: empowering patients, implementing modern general practice and building capacity, cutting bureaucracy and reducing the workload. And now all of this sounds just kind of absolutely what you'd expect us to be doing, but I think that the way that the primary care has been responding to this and the work that they have been doing has been phenomenal. It's been absolutely amazing to see, and I think one of the things that's helped us to do that very differently here within the Frimley system has been our analytical capacity using connected care, which has allowed us to focus on all of this through a population segmentation approach, which has been phenomenal in trying to do this in a different way. I think that if you want to go to the next slide, we can talk about the next bits. We've got lots of we're just moving through them. So you can see from the slides how we're working to empower our patients through using the NHS Act functionality. We're able to have 90% of practices for patients to see their own records and messages and book their appointments and order repeat meds using this app. If this isn't something you are personally already using, I'd highly recommend it. I love using my NHS app to do that, and I think it's a great way around patients being able to have that transparency. We've been increasing the self-referral pathways, ensuring that we can do that, and we've been expanding our community pharmacy services, things like oral contraception, blood pressure services, and the launch of Pharmacy First, which has a massive impact for our local population. Do you want to move to the next slide? Do you want to move to the other one? I think that I wasn't going to go through every single slide on the different pieces. I think there's quite a lot in here. If I move to the notes side, do you want to carry on? Because I think there's lots and lots of slides about empowering patients. So around, oh, I want to go back up one, Sam, about implementing modern general practice, sorry. So around about implementing modern general practice, our actions have been around delivering transformation and training to support all practices through the national offer. We've been working with practice to move to digital telephone system, and with callback functionality. And some of this has been really important in reducing the length of time that people have been waiting for to make appointments. And I think if you think about the things that people really worry about when they're trying to access primary care, it's, can I make an appointment? Can I get to see a GP? By doing those small things that make that easier for people has a massive impact on the way people access primary care. And I'm sure from a primary care perspective, it has a massive impact on the way people interact with them. So a lot of the work that I do with primary care exposes me to the impact of patients that are very frustrated have on our primary care staff who really feel it. So it's a really important dual benefit, both for patients and for the staff trying to deliver in a really difficult circumstances. And then it also provides all practices with the digital tools and care navigation training for them to adopt this approach. Do you want to move through to the next? And I think there's lots of information about implementing modern general practice. I'm just worried about time. Do you want to move to the next section? Building capacity. So I think part of this is making available an extra direct patient care staff to deliver more appointments. I think, one of the things that has come out over the last few years is how it's really important that people want to see primary care, and they want to be able to see people face to face. We've worked really hard in this area. We've expanded our speciality GP training to make it easier for newly training GPs who require a visa to remain in England. And we've changed local authority planning guidance to raise the priority of primary care facilities when considering how funds from housing developments are allocated. You want to carry on? Sorry, do you want to keep going? There's a lot about building our workforce, which has been phenomenal over the last 2 years. And then around cutting the bureaucracy, we've been working to reduce time spending liaising with hospitals through improving interface focus on the 4 areas highlighted within the RGCP report, and we've streamlined the investment and impact funds and protection of the cost indicators. The impact of doing all of this means that we've had practices working with us across the clinical pathways for primary care, secondary care, to bring a better understanding of the challenges it really makes a difference when they come together and align it. They know how to, when the clinicians from primary care and secondary care get together and talk about what the challenges are, they design really simple solutions that are better for patients and then better for all of the services. They make a much better job of it. So cutting that bureaucracy and allowing them to do what they do best has a real important action on making things better. We've been also monitoring locally with our local medical committees the impact from the action around collective action. So collective action is the title that's being used for primary care to work with us all on a national basis to try and ensure that they get a fair rate for their contract. What they're doing is they are looking at sensible things that they can do that shouldn't have an impact on patient care, that allows them to demonstrate their challenges around the contract settlement. Want to move to the next slide? And we'll go through the rest of the bureaucracy bits, and then there are lots of things. So we've got some key risks and challenges associated with the delivery of the action plan. So we've got practices who would most benefit for some of the transformation are our practices that are least able to commit and identify the leadership to do this. So many of our practices are able to do it and they've done it successfully, and we've got really good examples of them working to do this and it changing things. But obviously and it's many of our very smaller practices that don't have that leadership capacity to do that. So we are trying to support them to do that so that they can engage in this program of work, because ultimately, in addition to helping the population, which is it also helps the practices to in their ways of working. With the system under significant pressure, access to the necessary transformation resources could be restricted and impact on outcomes. We've worked really hard to ensure that the funding for this has been prioritised and that we've been able to maintain that. So, and I hope that that continues, because this is such an important piece of work. And then that secondary care interface that I talked about, that's really challenging to maintain that, but we have some really great leadership, both from the secondary care organisations, medical directors, and our medical director within the ICB to ensure that that interface works really smoothly and we're able to have those conversations that help us to align across primary and secondary care. Do you want to move on? So some of the successes that we've had, we've focused in reducing demand by engaging our patients differently. 100% of our practice websites are compliant with NHSE expectations, and we try and look at our practices websites on a regular basis to support that. That NHS app utilisation has increased by 22% and has increased for use for repeat prescriptions and appointment management. Again, shameless plug to make sure that you are using your NHS app if you're not already. And we've got practice-led capacity and demand plans for modern general practice. 91% of practices have code-signed plans and 47% have participated in the NHS programmes to support delivery. That programme really helps them to understand the benefits of and teaches them how to use the delivery mechanisms. We've lots of sharing of experience and best practice established. We've had a number of events where people have been able to see, so hoping to learn from each other and adopt things very quickly rather than reinventing it in every area. And then there's a better understanding of segmentation so that we can understand patient needs better. Building of capacity, there are 100% of our R's workforce. So the R's workforce is the workforce that is the other people that you might see in primary practice other than a GP. So you might see a nurse, you might see a pharmacist who will help you do a medication review, you might see a physician's associate. These are all different skilled workers that are targeted to doing things that will make a difference for patients, and can contribute to that multidisciplinary way of working within primary care. This has resulted in over 450 whole-time equivalents across our system. And then I think we've seen over 80 of our general practice have been assessed for improvement and redevelopment needs, with the new policies developed to include PCN essential needs in the ICB and estate planning. And then finally, around cutting bureaucracy, that bit around primary and secondary care colleagues working more effectively through reducing the bureaucracy and best practice adoption in the ICS engaged services, interfaces, evidences, better output. So, as I said before, doctors and other clinicians working together across primary and secondary care, simplifying things. It is really phenomenal, the work that primary care has done in this area, and we are really truly seeing the benefits of patients being able to access primary care in a better way.
Thank you very much, Sarah. Very helpful. And all of the slides are, of course, available in the pack. So thank you very much for summarising so fully. Comments and questions, colleagues. Gronya, thank you.
Yeah, thank you, Chair, and thank you, Sarah. That's clearly a huge amount of work that's been undertaken by our primary care colleagues. Recovery and transformation doesn't quite describe the volume of work that people are having to undertake while still dealing with the significant amount of pressure that everybody's under. So I think that's just my first point, just to note that. So with the volume of work that is taking place, I read the presentation, but I wasn't quite sure whether or not are we communicating things in the right way so that our residents are going to understand the improvements. So for example, the successes that we're reading there, what does that mean to Mrs. Toseland in Binfield, for example, in terms of what she experiences? Because sometimes we get so busy with the narrative and the jargon, I suppose, as we would describe it, but what does it mean to Mrs. Toseland in Binfield in terms of how she experiences, and would she recognise in a survey what those improvements had been? So that's not a challenge. It's just are we talking in the language of residents when we're explaining the improvements that we're undertaking in primary care? So, for example, our patient participation groups, I'm very far removed from that. So it's just a question, having read the huge amount of work that's underway, and just wondering whether our residents would understand that and therefore it get conveyed in the surveys. Thank you.
So, Gronya, really interesting the way you say that, and some of the reason for my slightly inarticulate presentation of that report was, as I was pre-reading it this morning, I recognised there was quite a lot of jargon in it, and I was trying really hard to de-jargonise the report, which I don't think I did that successfully, and will take that on board before the presentation of the next report, because exactly that, Gronya, I was thinking, what does it mean to the population and how do we convey those messages? And I think our primary care colleagues, through their patient participation groups, are probably far more effective at it, and work that. And certainly I know that I've been working with the partners at Sandhurst, well, it's the Frimley group, but in Sandhurst, because you'll notice in the latter report that they've had a challenging CQC inspection, and have been listening to how they've been talking to their population, and they definitely do talk to them in a language where they can understand, where the population can understand. So I think you're absolutely right, Gronya, is what does it mean in reality? And I think in reality there's four things, isn't it? It's that we are trying, everything that we're trying to do is to make getting an appointment and seeing the right person more easy for patients to do, and to ensure that it's streamlined between primary and secondary care, and it's not difficult, and that everyone's talking the same language, and that the bureaucracy for both patients and our primary care teams is cut. You know, if I was going to summarise the whole report into 3 sentences, that would be it. And that's hopefully the message that, well, I believe that's the message our practices are giving out.
Thank you, Sarah, and a good suggestion around the way in which we can capture all of that in a briefing. So thank you. Could we then go to Dr. Prash Patel and then Dr. Lalitha Iyer? Thank you.
Thank you, Chair. Thank you so much, Sarah. You're so wonderfully self-deprecating, because I was going to offer an epilogue, but I don't really need to. I mean, I just want to thank primary care colleagues. And in some ways, the report is dense, and I know I'm preaching to the converted, but you know, anybody from the public forum, there's some data and details in there that just shows the sheer amount of productivity, efficiency, and enthusiasm that's in primary care. But that couldn't have happened in isolation. There's something about all the partners around this board who are so supportive of that. And I would actually suggest that that's been a 5-year journey since we are operating through networks. But even before that, there's been a cohesion where there is willingness and ambition amongst primary care partnerships to work together. I agree with you, Sarah. None of that could have happened if we hadn't wholeheartedly adopted technology. The way we run our access points only works because we are, we're there ready to disrupt and to do things differently. So when we've got workforce issues and we can't find receptionists, etc., we're working in a technological way. Modernizing general practice, I think, for GPs in Frimley is a fait accompli, because actually we've been looking at those issues 5, 6, 7 years ago, and we've started to organize ourselves in these sort of hub fashions, far sort of in advance of where perhaps other parts of the country are. So I'm hoping that we can be very much a pathfinder for other parts of the country. Grani, you're spot on. I spend a lot of my time distilling this, trying to explain to patients that it's not entirely true that you can't see your GP. Or if I'm listening to something on the radio and they say it takes me hours to see the GP, I look at the numbers and I look at how many patients are attended to within 24 hours. Again, when you look at the performance data in our system, we are ahead of the national curve, and we need to sort of recognize it. And I can see Fiona's mentioned something in the side chat. We absolutely have to get this information, distill it down to members of parliament, to health and wellbeing boards. We've got to empower our local authorities to actually spread the good news, because this is off the back of 10 years of work and of 10 years of being really courageous in primary care. All my colleagues across the board are working differently and transformatively, and I think we're starting to see a lot of the evidence. And I know that the system is so supportive of that. So even though I know that there are challenges over the next 5 years, I think resourcing this, investing in this, looking at our digital capacity, which is really being led by primary care, we can only continue to lead. So thank you so much for that sort of detail in that report. I'm going to be spreading that widely, but it would be nice to be able to distill that into a really enthusiastic elevator pitch and just say we are doing a cracking job. And that's how we're going to manage upstream work and left shift work, by investing in our community and primary care services. So thank you, Sarah.
Thank you very much, Prash. And Lalitha.
Thanks, Priya. I just wanted to add to what Sarah's presented under the PCARB. And I guess the newest program of work that the Secretary of State and Amanda Pritchard have asked our National Primary Care Director and the National Secondary Care Director is to reduce the bureaucracy. It's one of the 4 pillars that Sarah alluded to in her presentation. And they are in the listening phase now, where they are looking at how can we reduce bureaucracy, not just in the interaction and the pathway for a resident or a patient between primary and acute care, but primary and mental health services and also community services. And out of the listening phase early next year will come out short-term measures, which as ICBs, we may all be asked to be responsible for enacting those short-term recommendations. And in the listening, anything that comes out as a strategic piece will feed into the 10-year plan that we will see later on. And I guess I was also reflecting on the Times article that's come out on how the NHS is going to be overwhelmed if we cannot empower our patients to look after ourselves, and how important that is that we support. And also going to the previous topic that Sarah spoke about, listen and then give them the support that they actually need to look after themselves so the NHS can actually function more productively. That's all I wanted to add to what has been said so far.
Thank you, very helpful. And thank you to everybody across the system who's been involved in achieving this. And thank you, Sarah, for leading our discussion. Can I move us then to our standing items? And although we are we're taking quality, finance and performance, and then workforce, I think Richard Chapman, our Chief Financial Officer, you will give Sarah a moment to breathe by starting, please, with our finance and performance. Thank you.
Should be absolutely delighted to do so, Chair. Thank you. So the finance and performance reports presented is the position as at month 6, halfway through the financial year. It shows a £1.4 million adverse variance to a planned £4 million surplus at that point, which looks comfortable, but there remain material efficiencies to deliver, and it's inevitable that operational pressures will drive further financial risk as we move through winter. There are clear year-to-date pressures when we analyse the position in direct variable costs relating to activity provision. So at Frimley Health Foundation Trust, we are seeing those pressures in drugs, in clinical consumables, and in the outsourcing of elective activity. Within the ICB's position, we are seeing those pressures, particularly in prescribing, and analysis shows that that is due both to price variances and volume variances on prescriptions made. We are, though, holding our workforce pressures and across both Trust and ICB, and we are holding in the area of continuing healthcare and care packages, where I know nationally the pattern is that those pressures are emerging and systems are seeing adverse variances to what they had planned in those areas. So I guess overall, the financial position is reflective of the very real demand pressures which continue throughout the system, and we see that in the performance data as well. So for learning disabilities, mental health and children and young people, the key focus there is on out of area placements, where at the latest available data we had 20 placements out of area where we targeted none at this stage of the year. That is on the risk register and is a key focus of work going forward. In urgent and emergency care, the 4-hour wait target was not delivered in September. We were at 69% against a target of 78%, and we have some clear actions to resolve that, both immediate and in our winter plan on an ongoing basis, including the co-location of the urgent care centre at Frimley Park Hospital, which is ongoing currently, and I think due to commence service within the next 2 weeks. In plan care, we're seeing continued improvement in the 65-week position, but we did miss the September national ambition of 0. And in primary care places and communities, and we just heard from from Sarah on the PCAR plan. So same and 14-day appointment performance is the best in the southeast and continues to hold up. Virtual wards, we are a leading system nationally. The occupancy and availability of virtual wards remain high, and work is ongoing to maintain performance on urgent community response. I'm going to pause there, Chair, and I'm happy to take any questions.
Thank you very much, Rich. Comments and questions? I will move us through, I think, to all of our reporting, and then we can come back to questions at the end. Should we move to workforce then, please? Caroline Corrigan, our Chief People Officer. Thank you.
Thanks, Priya. Yes, the short slide deck there, just picking up and building on Rich's commentary there. The top line being we're holding, or particularly FHFT are holding their performance well in the workforce domain. If we move slides, please, Sam. Sorry, let's hold on that one. So this is just the top line KPIs in terms of the FHFT performance, and continues to be a strong performance, particularly on temporary staffing, agency, bank usage. Again, we've got some comparators there against regional averages. We're building now comparative data with other NHS trusts on our patch, so same data sources for FHFT and SABP, but focused in the main on FHFT in this board pack. Next slide, please. The next two slides just provide a little more data and trend analysis. Thanks, Sam. If we move on, so vacancies and absence rates. I just want to hold on this, the ICS People Board. So this is our System People Board, chaired by Julian Ems, the Chief Exec at BHFT. We've met a few times now over the past couple of months, and I just wanted to particularly bring to the board's attention the focus. We've whittled down to 4 priority areas that system colleagues want to lean in and work together through the System People Board. We're meeting next week to agree a development piece, so 2 sides of A4 that will flesh out these priority areas so that we can agree the key areas to work on and how we will work together in those. As you can imagine, digital transformation there in the workforce domain is enormous, so it's a process of synthesizing down and being clear what it is the actual focus areas will be. FHFT colleagues particularly keen to work on a system basis around education, training and development, and obviously connecting that to the previous board discussions about leadership development is an area that's definitely one that we're expecting to finalise, and we'll keep the board updated with those particular work areas on the System People Board. Last area I just wanted to flag, you'll know that one of our strategic objectives, so Sam, the next slide, we were one of 15 areas in the country chosen to deliver the Work Well pilot. And this is just a very high level summary, given the that's a 2-3 year programme of work going well. We've submitted now, having got all of the programme management resource in place. The first quarter information requirements have gone to DWP, who are one of the main partners, and with DHSC, but coordinate overview of this programme of work, and the places in terms of proof of concepts, and particularly the Slough work ready for go live. So just wanted to make sure the board was aware of that. It's in our strategic objectives. It's a significant programme of work. We were very pleased to be selected as a pilot area, and perhaps in the future through the Living Well board, which oversights the programme, we can bring a more comprehensive update perhaps in the following quarters. That would be my highlights, Priya, and again, happy to take any questions at the end.
Thank you very much, Caroline. And should we come back to you, please, Sarah? And I know you will share with us changes in risk profile in the area of quality. Thank you.
Thank you, Priya. Actually, I've tried to pull together within this report a kind of winter assurance around quality for the board. I thought it might be helpful for us to see. So if we take the presentation and we'll start with the autumn-winter 24 vaccination campaign, you'll see from the data that we're not as far forwards as we would usually like to be at this point in time. I think there are two reasons for that. One, the flu and COVID campaign started a bit later than we usually do. We often see the flu campaign starting at the beginning of September, sometimes the middle of August, but it was more like the beginning of October this year. But secondly, we have seen a lesser uptake in the COVID vaccination this year. And as Fiona pointed out at the head of the meeting, this is the one important thing that people can do to prevent prevent winter illnesses for themselves. We started the RSV programme in September. This is a fantastic programme that's been developed, and it's covering our 75 to 79-year-olds and our pregnant women over 28 weeks. And we've so far had a good, we're pleased with the uptake that we're starting to see with that. We had NHSC ICB Accident Emergency Corridor Care visit to both of our acute trust sites at the end of August in preparation for winter. Obviously, corridor care is not something that anybody within the NHS would like to see happening, but because of the demands we've had, it is a thing that we're having to do. So it was an area that was important to have a look at. And if you are going to have to do it, I was really pleased to see the high standard of care that our patients within our system receive, and the privacy and dignity that is afforded to them despite having to have a corridor care. It's a really well organised, and it felt safe what they were doing if you had to do that. I just have to keep qualifying that it's not something that any of us ever would want to be. I wanted to point out that the Trust has had 2 Never events, and they are looking at those and working to identify any shared learning across the 2. You can see that they were both relating to wrong procedures, and you can see the learning that we've captured, and they're sharing that learning across their sites to try and reduce it. I've put in some information around mental health and the portfolio update for you, and really I've wanted to include some of the ICB mental health winter planning. Mental health is an area we often don't look at, and the demands for mental health are as critical as they are for physical health. They're just a little bit hidden. We talked about corridor care for patients in acute hospitals where it's very visible to see the numbers of patients that you've got, but for patients that require urgent mental health beds, when there aren't beds, you don't see that because they're held at home, and this is often on large caseloads and things. So it's really important that we make sure that we've got that visual to people, and that we are putting things in place to try and expedite that. So we've created new weekly adult complex patient discharge planning meetings. You'll be aware that we did this with children, and that reduced the impact of children being cared for in the wrong places, and we're hoping to see equal success with that. We're establishing some closer links with the housing providers. We've supported some additional roles in ED, and we're considering a move on a housing coordinator. We're continuing to support the Right Care, Right Persons ambitions, and we are supporting the mobilisation of a mental health recovery vehicle. So basically, it's the equivalent of a mental health ambulance with practitioners in there that can see people quickly. And we're putting out a provision of rolling out the crisis tech service, and we're working to develop an alignment of processes and pathways across the system. If I move to the next slide. Community pharmacy, I alluded to this in the primary care presentation as one of our streams to look at stuff. We've been working, we're one of we're working really hard on our rollout of Pharmacy First, and we're 24 out of the 42 ICBs. We're looking at more than 18,000 consultations that have been completed, meaning that those patients have received care in community pharmacies rather than having to access either GPs or other services. So I think that's a really big achievement. If we move to the next slide. Sorry, I'm just conscious of the time. Primary care collective action. I talked about this a little bit in the PCARP. As I said, this is an area where primary care is just working to contracted activity. That within our system, that probably isn't actually true. I'm very conscious that many of our GPs haven't actually implemented this, and we are monitoring it, and that monitoring demonstrates they're not implementing it, and we've seen minimal impact as a result of the national collective action that's been commenced. We've already talked about primary care, and on the day I probably won't go through that anymore, but there is some slides for you. And then I just wanted to talk to you about vulnerable migrants. We continue to have vulnerable migrants in the system, and we're continuing to support them to make sure that we provide the right care for this really vulnerable group. The Home Office has reopened a home in the RBAWM area, and we've worked to re-establish NHS support for this population. And I think the thing to sort of talk about with the vulnerable migrants is it's a very fluid movement, and certainly the population that we have in Slough can move very quickly and transiently because it's a 48-hour hotel. So we try really hard to meet the needs of those people. And then from a quality and CQC outcome point of view, you'll notice that we've only got 2 areas for requiring improvement and requiring an improvement in adequate across both of our ambulance providers. But I would say this is long-standing, and some really important significant work has happened for both of those providers to improve the standards of care. Many, if not all, of the quality and safety actions have now been completed for them. I think that's probably it, Priya.
Thank you very much, Sarah. That's very comprehensive. Comments and questions, colleagues? Bronya, come in.
Yes, in relation to the workforce report, sorry if it's getting noisy where I am, I do apologise. The workforce report, just to say, I've had some very, very positive feedback in relation to the learning and development opportunities that have been available for local authority colleagues. So I just wanted to convey that praise back to whoever the organisers were. So that's gone down really, really well. Just building on that, in terms of the joint education and training offer, I was wondering whether or not, given it's a priority for the new period, can we think about clinical and political leadership in that space? Because we come from 2 very, very different places, and often our political leaders might not fully understand the role of clinical leaders within primary care and the extent of their roles, and often difficult times, especially when we're talking about CQC, quality issues, etc. And maybe GPs may not always fully understand the local ward role of a ward leader who's been elected to represent, and why that person's so interested in all of the primary care issues, etc. So I was just wondering if there was something that we could consider in that space. So rather just from an officer perspective, we could actually think about that more system leadership perspective from the clinical and political leadership. So just thought I'd land that based on just my observations of some recent issues that I've observed locally.
That's so helpful, Gronya, and building on earlier comments about how we can build that mutual understanding as that base, really helpful to
Oh, I think
Priya's
Priya's
frozen.
frozen. Shall I just reply to the comment? I was going to reply to that. I think Fiona put in the chat previously around us trying to work with local political leaders and that understanding of all the work that's happening in primary care, and also when it comes to inspections and things. So Grania, I think that is something that we could do.
Thank you very much. And Graham.
Yeah, thanks, Sarah. I think I just wanted to pick up on some of those mental health points. So one was just to point out that we've got the first meeting of a new committee on the 5th of December. So next time we meet, we'll be able to talk about that a bit more. And I also wanted to talk about that regionally. I think there is now a big focus about people waiting for admission to a mental health bed. So we'll obviously be working within that regional context. And then I just wanted to pick up on two things. I think it's good news we're hearing that the crisis tech service is going to be recurrently funded, so we're working alongside that. And on the mental health response vehicles, I think, Sarah, there's still some debate about whether this is a crisis response service or a paramedic response service, and different parts of the regions have come up with different models of care. And I think that's still in the sort of boiling point of evaluation about which is going to be the best for people who are in a mental health crisis and need an urgent response. Is it a paramedic-led service, or actually is it a mental health trust-led service? So I just thought I'd add that as a flavour to what you'd already said.
Thank you. Thank you very much, Graham. Any other comments or questions? And Sarah, any final words from you, or Richard or Caroline? Okay. Caroline, can I move to you then for the BAF?
Thank you, Priya. Yes, I'm just sorry, just moving that. Apologies, the paper's just disappeared off of my screen, which isn't helpful. So colleagues will have had the opportunity to review the BAF. We've provided that in full. The cover paper summarises the current position. We've significantly refreshed the board assurance framework. We've made sure that it aligns now, having agreed our strategic objectives, that the BAF aligns to both the ICS ambitions, but also the strategic objectives of our board. We've given a reminder of the risk thresholds against domains, and also the risk appetite against those strategic objective areas. Whilst we can't do trend analysis because of the change, we've also just summarised in the cover paper the strategic objectives that are in and out of risk, and confirmed that the integrated risk group, which meets to review risks across from both the Finance and Performance Committee and System Quality Committee, the integrated risk group has reviewed that and also provided an assessment of the complex or more significant recurrent risks that are escalated via the corporate risk register. So that was a summary of the document as presented. I don't know, Fiona, I think you wanted to come in and comment on a couple of areas in particular.
Oh, I thought you would just mention, yeah, so the key thing in relation to the BAF is we do need to reflect on the risk around mental health, for example, that we've just touched on, and that was in our quality report, and be really clear about our risk appetite, because we rightly have set a risk appetite of cautious for quality and safety, but we have significant areas, particularly around mental health, in terms of children's access to neurodiversity assessments, for example, but also, as we've heard earlier today, the inpatient waits for mental health, that that we're breaching that risk appetite of cautious continuously. So it feels like we just need to have really focused attention through the work streams that people have mentioned, the mental health strategy work that we've established, that we both have the risk appetite right, which it is right to be cautious in quality and safety, but then what do we do? Are we really putting enough effort behind addressing the gap with the level of risks that we have had for some time in that particular area of mental health?
Thank you, very helpful. And come in, Graham.
Yeah, I just want to say, Fiona or Sarah, is it true that we've also got an issue, I thought we did, with adults awaiting diagnosis for ADHD and ASD? So it's not just restricted to children.
No, yeah, you're right. Sorry. I was just trying to make sure it was all ages. That was all. Yeah, thanks.
And come in, Ilona.
Thank you. I just wanted to say it's really good to see the progress on the BAF and the refresh. I think has been very thoughtfully done. So thank you for various people who've been involved in that. And Fiona, I was going to flag, I think mental health probably isn't the only area where we need to do that. I don't know what the right term is, but that kind of cross-checking in the logic of what we're presenting here. And if things are repeatedly showing as red in various ways on this within our risk management framework, that should prompt us to ask questions about, are we doing enough mitigation or not? Are we misrepresenting our risk appetite? Are we misrepresenting what we're willing to tolerate? Because the ones that struck me was that there's something similar around use of resources. I think we're just thinking through if the logic quite holds, and on living well in the people, places and communities. I was looking for perhaps even more assurance around whether our mitigating actions are going to get us to the position we think we would be comfortable with. So I'm also conscious we've timed out on this. So I was just pinging Priya a message saying, can we maybe move this up earlier in the agenda next time so we do it justice? Because I think there's really great information in this BAF, and having a fuller conversation earlier on in the agenda would be worth considering. But thank you.
Thank you. A very good suggestion. We'll do that. Fiona, come in.
Yeah, I mean, I agree, Ilona. I think it's pretty striking, though, where we've got the lowest risk appetite, and we've got. So let's start there, if you see what I mean, because and you're right. I think this is really maturing well, our approach to BAF and risk, and trying to make it an interdependent process. The visibility is really good now.
Thank you, and thank you all. So we've heard also about the mitigations and the streams of work around those areas that are of significant concern and ongoing concern, including through mental health. Thank you for that. We are now on to the final part of our agenda. We don't have any questions from the public today. We often receive questions that are of a commercial nature, and those are managed outside the board. I'm going to ask colleagues then, is there any other business? As I look around, and I can't see any. So thank you very much to all colleagues. Thank you to all of our team for hosting today's meeting as well. We are next meeting in public on the 21st of January. Thank you all. Take care. Bye-bye.
Thanks, everyone. Thank you.